Hello, everyone. I'm Sherry with the CGH Health Foundation, and welcome to our Growing Healthier program for November. This is our series of educational programs where we present important health information, and it gives us a chance to introduce some of our providers. And the program's always hosted by Dr. Bill Bird, who's our Chief Medical Officer. In today's program, Dr. Bird is going to be talking to Marian Kavanaugh, Dr. Marian Kavanaugh, who is in our podiatry department, and she's a surgeon, and she's going to be talking about what you can expect if you have any advanced foot surgeries, and also how to keep our feet healthier. So this will be a good program. We don't have a program scheduled for December, and we're working on our 2026 schedules. So we'll have more information about that on the CGH Facebook page and also in our Healthlines newsletter. So be watching that when it hits your household. At the CGH Health Foundation, speaking of Facebook, I just wanted to mention that the CGH Health Foundation does have its own Facebook page. And so if you haven't already liked us, please go out and look for that and follow our page. And since it's November, one of the things that you'll find out there are information about our many services for Alzheimer's and dementia. November is Alzheimer's Awareness Month. And we have support groups and classes, services to help with caregiving, dementia respite program, and all of that information will be posted on the Health Foundation's Facebook page, as well as content that is cooking videos done by me and the newspaper article that I write for the Shaw newspapers. So that's what we have going on. I'm going to go ahead and turn it over to Dr. Bird so he can have his interview with Dr. Kavanaugh.
Thank you, Sherry. Appreciate it. Hi, this is Bill Bird, Chief Medical Officer at CGH Medical Center in Sterling, Illinois. Thanks for taking the time to watch. And today we're going to talk about feet. We're going to talk about feet with Dr. Marian Kavanaugh, our newest interventional podiatry physician here at CGH. I'm looking forward to talking with her and picking her brain about your feet and what you can do to help them out when they're not healthy and how to try to keep them healthy. So with those thoughts in mind, let's get Dr. Kavanaugh on the line.
Hi, Dr. Bird.
Hey, Dr. Kavanaugh, how are you?
I'm good. How are you?
Good. Thank you for taking the time to answer a few questions.
Absolutely.
And speaking of which, the first question I'm going to throw out there is just to tell us a little bit about yourself since you're new to CGH.
Yeah, absolutely. Well, thank you for the introduction, and thank you to everybody at CGH for my warm welcome here. I am originally from the northwestern suburbs of Chicago. I am from a really large family. I am the oldest of 8, and so just constant craziness throughout childhood and growing up and whatnot. I played a lot of sports, none of which I was really ever that great at, but played a lot of soccer. I played lacrosse in high school when it was brand new to Illinois and there was no competition to join any team. So I've always been really interested in fitness and health and just trying to find ways to be really active in my own lifestyle and how to live a healthy lifestyle. When I went on to undergrad, I went to Bradley University in Peoria. And through my pre-medical training and really just through all of my classes, I did a lot of shadowing through a lot of different types of specialties within medicine itself. And I'm biased even in my own interest with medicine because my dad worked at CGH in the emergency room for many years as I was growing up. And so I was very lucky to see and be underneath a lot of different types of doctors. And in undergrad, I kind of fell upon podiatry by happenstance when I shadowed someone in an orthopedic group who was the podiatrist there. And he had the coolest clinic that I thought really encompassed so many different things, a lot of preventative care for sports injuries, treating them. It was the first time I was ever in the operating room, and I thought it was a very cool place and really always inspired me to look into that. And so that's how I found podiatry, really through that, is sports and wanting to make sure that I'm helping people like myself when I was growing up, playing all these different types of sports and whatnot. And so that led me to applying for podiatry when I went on to medical school in Rosalind Franklin. I in the northern part of Chicago. I, from there, matched at Georgetown and spent 3 years doing a podiatry surgical residency out there, pursued a fellowship that really encompassed a whole lot of more orthopedics with trauma and advanced reconstruction. And so I feel like I've gotten this really well-rounded training experience that I am excited to bring to CGH and the community at Sterling to really help bring people a full encompass of care. So that's a little bit about myself.
Yeah, very good. Thank you.
Yeah.
You mentioned being healthy and helping yourself be healthy and your patients be healthy. Before we get into unhealthy things, or not unhealthy, but problems that people have with their feet,
Right.
I want to give you the floor just to talk a little bit about your recommendations or what you're seeing in terms of people and their bones and trying to keep their bones healthy. Marian, can you speak to that?
Of course. And I thank you for giving me the floor to speak about this, because so far, while I've been at CGH, I've done a lot of fracture care. And oftentimes this isn't something that people plan to have, these types of injuries. You're often outside trying to be active, and when you step off of a curb, accidentally fall from a height, any sort of type of injury that often can result in but often can result in an ankle sprain. Often some of these people are really fracturing a lot of their bones. And as I've seen so far, and this is not just to the Sterling community, this is everywhere in the US, is that there's a higher rate of fractures that are going on, and especially people above the age of 50, where we're finding that a lot of people are more fragile. And so these specific subset of fractures that are coming in are under the category of a fragility type fracture due to the health of people's bones. And so what I try and incorporate a lot into my practice thus far, and really just trying to treat people as a whole, is trying to put people on supplementation as early as possible. And something that I think could be a big key takeaway from our conversation today is vitamin D supplementation. Not only that, but as long as calcium and K2, all three of these help your body create strong, healthy bones. And so as much as we can to combat a lot of the osteoporosis diagnoses that happen in people over the age of 50, especially postmenopausal women, trying to make sure that we're mitigating some of these. And so I think something that could be helpful is, if you're not already taking a supplementation, to even start incorporating that into your daily vitamins that you may already be taking. And so I think that's something that could be helpful, because I find that so far a lot of these, especially as we go through into winter, you have black ice, a lot of injuries that happen during these times. You're shoveling snow. Often people have a lot of these injuries that happen, and life happens. And as much as we can to get people moving and back to their life as quick as possible, bone health plays a big part of that.
Do you have any recommendations for someone who's watching us in terms of, let's say, a postmenopausal woman?
Mm-hmm.
How much vitamin D, how much calcium, how much any supplemental potassium that you recommend that they take, or any particular vitamin or vitamins that they take in terms of their bone health, Marian?
Yes, I looked up some practice guidelines from an endocrine society, because there's so many different over-the-counter types of supplementations that you can take, and it can definitely be overwhelming. There's a very wide range of doses that people can take. And so as a general guideline for anybody over the age of 50, the Endocrine Society says that you should be taking 1,500 international units of vitamin D. And so that on the bottle itself will say on the back how much in international units, which will be IU. And so anything, I tell pretty much all my patients of pretty much any age, if you're not taking it already, at least baseline be taking 1,000. And on that specific bottle, to make sure it says vitamin D3 with K2 on it. And D3 helps your body absorb it a little bit better versus D2. And so making sure on those bottles it says vitamin D3, and that K2 helps your body make sure that calcium gets placed actually into your bone. And so the combination of the two, and then the calcium supplementation is not something that is a standardized amount, but is something that in any I would recommend just any over-the-counter supplementation for vitamin C. And I even tell my patients, because if they came in, Dr. Bird, if you came in with a fracture and I knew that you had weaker bone or something along those lines, I put people on a once weekly dose of 50,000, which is a lot. But in that time frame where you're asking your body to heal a large area at the same time of their vitamin D dose, I tell patients to take one Tums supplement at the same time, because that has calcium in it. And I learned that on a peds rotation, because it's very difficult to get kids to take a bunch of medications. So it's easier to remember to take one Tums with your once weekly vitamin D. So if that's something that is a little bit easier for your calcium, but it's a combination of the three. And that's typically, I would at least tell a takeaway is 1,000 international units would be a good starting place. And of course, this is all recommendations on the basis that you're speaking with your primary care about this, because everybody has nuances in their health. But I think that would be a great place to start.
Very good. Thank you.
Yeah.
All right. Let's talk surgery.
Yes.
So just for the folks who are watching and wondering, like, well, what kind of surgeries would Dr. Kavanaugh do? Can you talk a little bit about what are some of the common surgeries that you perform for patients?
Of course. My surgical practice is very wide, and really I hope to treat any type of ailment that people come in with their lower extremities, from the tips of your toes all the way to your mid-calf. And so things that I find a large interest in myself are sports types injuries, people who may have had an ankle sprain, but those never healed quite correctly. And that is a stabilization of doing that type of surgical treatment for that. I do a lot of fracture care, which I also very much enjoy doing. I enjoy putting that puzzle back together and getting people on their feet rather quickly after surgery. I tend to walk mine at 2 weeks after an injury, which is the newer literature to get people to walking sooner. It's a dogma that we keep people off of them for sometimes up to 2 months. And so that's a part of my practice. I am trained and certified to do ankle replacements. And so any type of arthritis through a previous injury that you may have. It's interesting, the ankle's a very unique part of your body when it takes a very large load. And so if you had a fracture, let's say when you were in your 20s, that got treated non-operatively, any 1 millimeter of displacement within that joint changes the contact surfaces by 42%. And so often when you have a type of injury that got treated, not to say that it would have been treated poorly, but anything that you have had an injury to that area, your rate of arthritis is much, much higher. And so as opposed to your knee and your hip, that is much more susceptible to a wear and tear type of arthritis. Your ankle is often an area where it doesn't get arthritis until you have an injury, but then it happens really fast.
Okay.
So I want to be able to give that to the community of Sterling as well. And so I do ankle replacements, ankle fusions, and then of course bunions and hammer toes and other things that are a common ailment, I think, for people in their feet, midfoot arthritis, any sort of ailment really. But I tend to take a strong interest in any sports types injuries, and then arthritis as well.
When you say sports injuries, and you say up to mid-calf, Achilles tears, is that something that you also do?
Yes, Achilles ruptures, Achilles tendonitis type things. There's a specific diagnosis that is, there's an eponym called a Haglund's deformity, but it's often a larger part of your bone that's prominent in the back that causes some tearing, interstitial tearing in your Achilles back there. And so that's one that we commonly perform, where we remove that part of the bone and then also clean up the Achilles tendon back there too. So yes, the Achilles is a part of my practice as well.
Okay, that's interesting. Is that a preventative type of thing to try to prevent Achilles complete tear if patients are having kind of some of those symptoms down in there?
It is, and it is something that I wrote down as my key takeaways.
Oh, okay.
But I think the part of when we have any type of foot pain, and it's either very commonly it's a tendinitis type issue somewhere in your Achilles, your plantar fascia, somewhere where it's an overuse versus a osseous, a bony overuse. So like a stress fracture or something along those lines. And so a lot of people don't think about the back of your leg and your Achilles being one of those deforming forces. But yes, I think for your overall health, always stretching the back of your legs, including your hamstrings and your Achilles, is going to help prevent a lot of things.
Okay.
Yes.
So foot pain wise.
Yes.
When is foot pain such that a person should say, you know what? I think I should see Dr. Kavanaugh.
No foot pain is normal. And I would say that I wouldn't jump the gun to say that you need to see a doctor the first day you start having foot pain, but there is often a overuse action to a lot of these, or some type of structural reason why people are having pain. So my fellowship director would always tell people, if your pain is affecting your way of life and your daily activities, you should see someone and you should think about fixing it. Because often when it gets to that point where it's affecting everything you do, you can't be active about it and you can't be doing the things that you want to do, then there's a conversation that we can have to get you, that's a goal, and I want to help you get to that goal. It's definitely, if your feet hurt, everything hurts. And so it's definitely, if you have it, I hope to help you get out of that.
Yeah, good.
Yeah.
I'm going to go, let's talking about your feet hurting. There are some people whose feet don't hurt and they should.
Yeah.
So let's talk about diabetic patients.
Absolutely.
And kind of the situation with them and how you take care of those patients, and when diabetic patients should perhaps see someone like yourself.
Diabetics are in their own category when it comes to this, because like you said, they don't have their protective sensation when it comes to having a response to pain. And so when you have a longer term high blood sugars really attack multiple systems of your body, like your eyes, your kidneys, and your nerves. And so when it becomes this more neuropathy, numbness, tingling, all the time type pain, and really just probably not even pain, but when you are numb often and people always start with their primary care, and you should have an establishment with a primary care, probably an endocrinologist as well, to really help get all of that under control and get your A1C controlled. But I think anybody with a diagnosis of diabetes should go to their primary care, who then refers them to us for a risk assessment. And I like to call them a risk assessment, because at that point in time, if you came in, you were a new diabetic with all of the overwhelming information that you get from being diagnosed with diabetes, you don't want the added stress of being worried about having a multitude of different issues when it comes to your feet and diabetes. So if you come to our office with a new diagnosis of diabetes, we say, okay, we see nothing here that is a risk of having skin breakdown, any wounds that are long-term, other things that may be a issue for people. That is usually a point where we say, okay, you're good for a year, and we'll check in on you every year. And so if you came in and there was an area that we were concerned about, we would say, come back in 6 months. And then there would be a relationship established based off of where you are by the time we meet you. But I think anybody with a history of diabetes should make sure that they start with their primary care, who then refers them out to ophthalmologists, podiatrists, nephrologists. Usually there's a whole slew of different people that help those people that have diabetes. And I can't imagine how difficult that is, but I know that if you have it, then we're here to help you and at least give you a little bit of peace of mind.
Sure.
Yeah.
When do folks who are diabetic need I know your office takes care of those folks in terms of specialized shoes and stuff like that.
Yeah.
Tell me about how that comes into play and who needs those.
The specialized shoes, there are diabetic type shoes that have inserts in them with special material, because when you have a lot of shear motion through your shoes, through just really your daily activities, that excess motion and heat can also cause your skin to break down. And so there are special materials that, through our third party, often with a hanger or with CPO. There's other companies, there's multiple companies that we use where we send out a prescription for an accommodative orthotic, which is typically something that has multiple layers of a material that stops that breakdown and cushions the area that is at high risk. And you don't have to be a diabetic to get an orthotic either. I think those are important for a lot of different types of structural deformities that are painful for people as well. And so we can also prescribe functional orthotics that help people as well. For diabetics is one bucket of orthotics are very helpful, and the literature supports that. For everyone else, when it comes to orthotics, there's no literature that supports that custom expensive orthotic is better than an over-the-counter orthotic. And so we usually always start with the over-the-counter option because one, it's it's cheaper for patients, and two, it usually gives that support that you typically need without having to do the whole process of getting a custom orthotic. So back to your question, I would say that the specialized shoes and the inserts that come with them are something in combination with myself and the primary care send, and we get them those shoes because it helps a lot of it's preventative, and it's a type of preventative medicine, and that can bleed into a whole different conversation about shoes and inserts. But that's what I would say about that for diabetics.
Sure. And this is kind of a broad question. But I'm just gonna give you an opportunity here to, like, in the course of a typical day, what are like the top few problems that you see with people's feet, and how do you go about treating those problems, just so folks can kind of have an understanding of that?
Sure. I would say that in my specific practice, I so far have seen a lot of overuse type injuries, and that's one bucket of typically plantar fasciitis, Achilles tendonitis, bone reaction, stress fractures. We have a really active population, I've found so far, and I think people want to be healthy and they're trying to be healthy. But then the catch-22 is when you go from a sedentary, maybe I'll work out, to a really active lifestyle. You often have a lot of structural changes in your body that's saying, oh my gosh, we're going.
You go from your couch to the pickleball court, right?
We're the couch to 5K people.
Okay.
I think the overuse category of what I typically see in a day, if we talk about plantar fasciitis quick, that's typically an inflammation of the insertion of your plantar fascia, which is a very large ligament on the bottom of your foot. That attaches on the same bone where your Achilles inserts. And so it seems counterintuitive, but what causes plantar fasciitis is a tight Achilles. And then people who come in with Achilles tendonitis is caused by a tight Achilles. And so the treatment for, if you came in and you were 10 out of 10, you can't get out of bed, the first couple steps are like someone stabbing your foot. I try and get people out of that pain cycle first with typically steroid dose pack or anti-inflammatory medications, because you can't stretch if it hurts. So trying to get people out of that pain cycle first.
Okay.
And I have been sending a lot of people to our physical therapy department. When I started here, I got to toured their department. I met Jeff and a lot of people at physical therapy who are so far been wonderful. And I think they really take an interest in the people that come in there, and they're able to get them in fast. Because sometimes physical therapy, you got to wait a couple months to get in. But I send people to physical therapy because the irony is I get plantar fasciitis quite often, actually.
Okay.
And I don't even listen to my own instructions about stretching at home. And I tell my patients that. I'm like, you can stretch at home. I just know you won't push yourself because I don't even push myself. So I do anti-inflammatory medication. I typically will instruct them about home stretching exercises versus physical therapy, and then support whether or not that is a good shoe. And we can talk about good shoes because I think that would be good for people too. But then, or inserts, something that really helps support that area. But so overuse category, I would say I've been seeing a lot of fractures recently in that vein, and a lot of ankle sprains in so far. And so a lot of people, like we were just talking about, want to be active, but then they trip off the curb or they do something and they have always had a really floppy ankle and they feel like their ankle is going to give out on them. And at that point in time, your ligaments aren't as strong because people want to walk off ankle sprains all the time. It happens, it's annoying, it hurts. And then
they're done that.
And so it's definitely the most undertreated injury in the body. And there's probably no literature to say that, but I would venture to say it's the most undertreated because I think a lot of people want to get back to their daily activities after an injury like this, but often you really have to rehab it appropriately and really get yourself strong again. Because if you have an unstable ankle, that's often when it's very painful. We have to fix them, or it happens again and you break something instead. So I think those commonly are what I see right now in my practice.
Very good. Well, I think we could talk about a lot of things for a long time. Dr. Kavanaugh. I hope the patients, the folks who are watching this, get a sense that obviously Dr. Kavanaugh is very knowledgeable.
Thank you.
Very personable, and has a really good idea of, if you have some foot issues, how to take care of them. So if those of you who are watching could take that away, because I can guarantee you that all three of those statements are correct.
Thank you.
And to, when things pop up for you or your friends or family, to think about Dr. Kavanaugh and the rest of our podiatry department at CGH. Oh, thank you. Give her a shout out and have her help you with what's ever going on with your feet. Like I said, we kind of went off script a little bit today.
I know.
And that's okay. I had a bunch of questions, but I think people.
You did.
I think we got a really good sense of what's going on and how Dr. Kavanaugh can help patients. And so, please feel free to share this with others so they can kind of get a sense of that too. And Dr. Kavanaugh, I promise I'll have you back, and maybe we'll be more on script next time in terms of knocking things out. But it's been great to have a conversation with you.
You as well. This has been great.
And it's great to have you on staff. And
thank you.
Yeah. So thank you, and I'll let you go about the rest of your day.
Okay. All right. Have a great day, everyone. Thank you.
I wanted to remind everyone, or let everyone know about a few other things going on here at CGH. First of all, I want to congratulate Megan Larson, one of our case managers, nurse. She does a lot of work to help patients in the emergency department and throughout the hospital. Very deserving of Employee of the Month. So congratulations to Megan. MyChart. So we've gone live with Epic, which is a new electronic medical record here at CGH. Very excited about that, and also very excited about, for patients, the ability to sign up with MyChart. I have it now, and I had an appointment recently, and it's really nice, really slick, and I'd encourage you to do that. We do have someone right now at the main clinic who is there if you go in, who can help you if you have any questions, and also there's a help desk here, the number you can call in if you're having any issues getting signed up with MyChart. Yep, we need some blood. Always need blood. There's the next blood drive time, site, and everything. So give us a shout out. We Very much appreciate if you're willing to donate. Seasonal lights are happening pretty soon. So be looking at that here. And if you are someone who would be interested in donating to help us with those lights, because it ain't cheap to put lights up and to take them down and have them shine. So appreciate that. And finally, want to wish you all happy Thanksgiving. Same for Christmas and New Year's. We will not be having Facebook Live in December, and so we'll plan on seeing you back in January. So between now and then, hope you have a wonderful holiday season. I think that's all that we have for today, and so thank you for taking the time to watch this, and I will be seeing you all back with a guest in January. So until then, this is Bill Bird, Chief Medical Officer at CGH Medical Center.